machine. So there, these automatic stop orders are more useful, not in our Indian setting. So definitely diagnostic stewardship support should be from the microbiology lab and support from the hospital infection control prevention unit. So IPC and AMS are like the two arms of the infection prevention control, definitely. So they usually should work hand in hand. And IT wing, this is all the technical data. So CDSS system, we are having our own CDSS system. So let's not go into details. Okay. And surveillance. So again, this is, so surveillance in India, IBAR IPC module, the JIPMER is doing a surveillance program, antimicrobial resistance surveillance program. We were a part of it for, I think, briefly over 6 months time. We can again renew for that. So they, what they do is they collect data from all the colleges that are in part of the team, and this IBAR is directly, it's available openly, so you can go through that and see what is the antimicrobial resistance all over the country. Okay. Okay. Again, this is just HIS system. So framing. So what did we do for framing of the antimicrobial policy? So this is the front cover of our antimicrobial policy. So in the forward, so what were our specific goals? What was our commitment? I'll just read the first, second and third para and we'll move on. So the policy reflects our institution commitment to optimizing clinical outcomes while preserving the effectiveness of the antimicrobial agents. It outlines a strategic framework for responsible use of antimicrobials aimed at minimizing the morbidity and mortality associated with resistant infections, and obviously in a cost effective manner. So our specific goals were to optimize the clinical outcomes by reducing the burden of the antimicrobial resistance through targeted and evidence based. So I want to highlight this point, evidence based treatment. So we are in the era of evidence based, not like the previously 20 years or 15 years back clinical diagnosis was okay, that was chalega, people used to accept it, but are we really in the player, can we really do this clinical diagnosis now? Are we really that, not just confidence, patient might sue us if something goes wrong, right? So that's why more people are opting for this evidence base. And secondly, to minimize the unintended consequences of the antimicrobial use, including drug toxicity, the selection of pathogenic organisms, and emergence and the spread of resistance. So, and finally, to prevent the healthcare associated infections through a coordinated stewardship of an infection control measures. So this is our policies table of contents. So basically we categorize the antibiotics. They are nothing but aware. Aware is access, watch, and reserve. It's a mnemonic for access, watch, watch, and reserve. So we have our own aware groups, and we are always welcome for new suggestions. And dosage is pretty much standard. And institute antibiogram, I want to show you this also. And we want to implement, this is something very new, very few hospitals have done this, antibiotic care bundle, this one. So this, I want to discuss this in the next slides. And remaining are just syndrome specific approach. Okay, and that's that too. Yeah. And prophylaxis, Dr. Shivanvesh will be dealing that. So this is our antibiotic categorization, aware, access, watch, and reserve. So reserve is the group that needs pre-authorization. So there was a little bit debate whether to add meropenem in watch or reserve. So it's again completely institutional policy. So my personal opinion is, after seeing the antibiogram, meropenem is the empirical therapy that should be given in our institute. So I would advise that it be in watch rather than in the reserve, because reserve drugs are all should be pre-authorized. So this is our hospital antibiogram. So if you can see the highlighted parts. So the thing was, I had very limited time in making this antibiogram. So this data ideally should be divided as OPD patients, IPD patients, and ICU patients, and emergency patients. But however, the limited time and limited patients, we have clubbed everything. So ideally, we will review this in after another 3 months. So, but see, the common organisms are, most of you know them, and the common isolate, common sensitivity was seen to Colistin, obviously colistin can't be given as an empirical therapy. Then meropenem and aminoglycosides. So similar pattern in all. Okay, colistin was sensitive in everything. However, colistin is never to be given as an empirical therapy. So apart from that, if you can see, meropenem was sensitive in most cases. So that is why I have kept meropenem as the empiric antibiotic. However, this should be again revised because OPD patients, we will not obviously give meropenem, right? So again, for crab and DTR pseudomonas. So in that, again, empiric drug of choice will be carbapenems. And for this, there is no empiric therapy or anything. You should only go by culture and sensitivity report. Okay. So this is for, that's for gram negative and this is for gram positive. In gram positive, if you see, again, empiric drug of choice for MSSA was typical anti-staphylococcal penicillins only. Then for MRSA, obviously it was vancomycin. The typical therapy, most institutes are following this only. So our susceptibility has also come similar to that. This was the individual antibiogram of Enterobacteriaceae family. Again, for Enterobacteriaceae per se, however, the isolates were few. Only Equal and Klebsiella from the Enterobacteriaceae were isolated. So meropenem again was the empiric antibiotic. Okay. So this is the standards that we should ideally follow. So CLSA again have developed a set of guidelines. That is a book called M39A. So according to that only we have designed our antibiotic policy. So ideally it should be reviewed and updated periodically, ideally 6 monthly, but we want to do it again in 3 months because of the limited time and data. And yes, this has been done. Antibiotic stewardship committee members have signed on the first final draft, and we are completely open for suggestions. Please go through that. Okay. So education and training. So this part, we are currently starting this. So again, this leads monetary support. Okay. So active interventions. So passive interventions are like studying this and meeting, like today's session itself. So active interventions are focus groups, hands-on workshops, one-on-one targeted. So let's leave all those. So prospective audit and feedback and clinical case discussions. We are already doing clinical case discussions, but it will be better if we start it on an antimicrobial approach rather than enter clinical approach. We want to involve, if this is involved, that would be great. Antibiotics, how many we are using, why we are using, if that discussion is also involved, that would be very nice. And yes, so educational intervention. So while I was working in AIMS, what we did was, so this displays in public places, there was an antimicrobial awareness week in November. So this is my personal experience. So what we did was, we did a walkathon for 5 kilometers to and fro. The terminal point was a park near the AIMS. So it was 5 kilometer distance to and fro. So there we have set up certain placards so that it was a typical Sunday morning. So many senior citizens, many people had come to the park. So this is like basic awareness they got, like what we could tell in that 15-20 minutes time. We gave a basic orientation to them. So that can be implemented here, or lesser calorie burning. Okay. So, okay, patient education. So yes, this patient education is going great now, quite nowadays, right? So Google is telling everything and more. Okay. And finally, our message should be easy to understand and evidence based. Again, evidence based is the emphasis that I want to mention today. Our antibiogram is also evidence based completely. I didn't cook it up. It is purely whatever we got. Only thing, we doubled the numbers because of time restriction. Apart from that, it's purely what we got in the lab. And yes, basic hygiene and IPC practices. This is already being done. And limitations of patient education. So obviously, time consuming and resource constraint, definitely. Okay. And implementing strategies. So these are the basic strategies that various guidelines have suggested us. So this is the last slide which I want to discuss in detail, then we can wrap up this session. So front end strategies and back end strategies. So front end strategies are more restrictive strategies. They are like prospective strategies. Back end are easy, retrospective strategies usually, and resource driven and guideline based. So coming to the first one, front end strategies. So formulary restriction and pre-authorization. This is something we want to start in our hospital. This is not there till now. So yes. So already we have discussed about the aware group. So if you can note, is it visible? If not, please open your WhatsApp groups and take this page number 20. So if you can see this care bundle. So what we are trying to do is, they are obviously most of the patients in our hospital definitely have antibiotics. So initiation, we designed like a 2-part care bundle. One is initiation and maintenance. So in initiation, we will this is only tick mark. Okay. So clinical rationale for initiation of the antibiotic. Why have we initiated it? Then appropriate specimens were sent before initiation or not. Then adherence to the local antimicrobial guidelines. Then following hospital authorization guidelines. And any indwelling catheter is already present in the patient. So most of the patients come referred also, right? So this category is for them. Then any other active interventions are there to manage. Okay. And finally, renal parameters. So that was taken in initiation bundle. So we are open for any other extra suggestions, or if you want to delete also, you can tell. So then continuation bundle or maintenance bundle. So in this, escalation of treatment is there or not, or de-escalation of treatment. So most of the times, if the patient comes to an emergency, you're suspecting sepsis or something, what do? We give a gram positive and gram negative coverage first. So after getting the basic gram stain reports, what do? If there is no gram positive organisms in the gram stain report, we should ideally de-escalate from vancomycin, right? The empirical drug of choice for GP is vancomycin. So such like that, are there any de-escalations there or not? Or if the culture report has come and the patient is resistant, carbapenem resistant organism is there. So meropenem, most of the time meropenem will be going on in the empiric therapy. So it should be escalated to the next drug, colistin. Or if it's an MBL producer, you should be giving ceftazidime avibactam aztreonam combination. So based on the type of the organism, we will be escalating it or not. So this will be mentioned in the continuation bundle. And this is a very important step. Is the patient supporting to the IV to oral switch? Is the patient palatable from IV to oral? That should always be mentioned. And stopping of the antimicrobials. So after a certain dose, is the antimicrobial stopped? Again, for that, the various antibiotics used. So this is in continuation with this only, care bundle only. So we want to include multi-drugs that are going in patients, not a single drug therapy. So at least 2 or more. So best example I would like to take here is CRE or CRAB. So if such organisms are there, definitely the patient will be on multi-drug therapy. So we want to include those kind of patients, and we want to start this basically in ICUs for beginning. So based on these days, we can calculate the duration of therapy and define drug dosage that we are giving. Okay, and are we in accordance with the WHO guidelines or not? That's a different story. So this is for that. Okay, this page. Okay, so and surgical prophylaxis audit. So prophylaxis part, Dr. Sivanvesh again, he will cover it. So for that, this is the audit checklist that we designed. So indication for the treatment, broad spectrum way, if you are suspecting a UTI or whatever basic syndromic approach that you are going for, then initial review of the antibiotic. Okay, so sorry, this is the old format. This continuation for 10 days is not there. We have only included 24 hours and 48 hours because it's a prophylaxis audit. We have only included 2 days duration, day 1 and day 2. And empirical audit checklist. So here, see, this is where our pre-authorization drugs, the aware slide that I showed you, that will come into role here. So if you want to, so pre-authorization ideally should be done by designated people. Mostly it's MSR. And Emergency authorization. So, but most of the times you're in emergency, you want to start with meropenem, and we kept it under reserve group. So you can't wait for a pre-authorization, right? So in that condition, you can always do an emergency authorization. Just you can give your reason why you are starting on meropenem, and you can always get the drug. So this is a part of formulary restriction that we are trying to implement in our institute. Yes. So this is the more detailed one. So these both are same only, antibiotic checklist and empirical antibiotic audit checklist. Only thing here we will add the risk assessment. So risk assessment includes these biomarkers if they are done. So if you are suspecting sepsis, obviously we will need these lactate, procalcitonin, CRP, basic biomarkers which we do, and our WBC count can also be arranged there. So and microbiology cultures have been sent or not, okay, and review after 48 hours. So again 0-hour assessment followed by 48 hours, because usually 48 hours and you will receive most cultures you will receive by end of 48 hours. At least you will know the organism. So after that, are we continuing the treatment, escalating it, de-escalating it? Again, this is a basic checklist. Okay. So yes. So let's wrap up our session. So why antibiotic stewardship has become such a difficult thing to start? Because there are so many things, factors influencing the prescriber's mind. So first thing, prescriber's belief. Okay, definitely clinical experience is obviously more better than guidelines. Obviously, see, most of the times cases where we have given in our urosepsis case, piptaz was resistant in vitro, but the patient was recovering on piptaz in vivo in real time. So in that condition, do we really, according to the guidelines, do we really de-escalated to meropenem? No. So that is always clinician's experience. The patient is recovering, don't do anything. Even if it is a resistant bug, resistant organism, resistant antibiotic on paper, you don't have to do anything. And policymakers, obviously, most the policymakers at national and international level, do you really think they do rounds, they do this bedside experience? No. And trusting your seniors over guidelines. So it's like just the child and parent bond. So always, even they don't change even if it is wrong. So you always believe that your child is good and innocent, even if they're doing a mistake, right? So hierarchy, obviously, seniors say, juniors follow. That's always there in our setup. And prescribing etiquette, yes. So non-interference. Even if you know that something doesn't work, you don't try to poke into their treatment, right? That is a professional etiquette we have. We most of the places that is there. And opinion. Yes. Okay. And sometimes even big institutes mistakes. So opinion. Sometimes opinionated readers, they might deliver the wrong information. Wait and watch policy. Usually patients don't like that. You know it's not necessary. So that is later what happened. So even if a monkey tried to go there, the other monkeys used to beat him. So okay. So they started replacing one by one, like the banana. Then again, irrespective of showering cold water, we stop one antibiotic and give another antibiotic with the close similar spectrum. So for I want your feedback on this. So this we practiced back when I was in AIMS. We seriously practiced this. So we divided the drugs into first line, second line, and third line. So if more than 3 different microbial classes were sensitive in the first line, then we stopped releasing the second line reports. So the more higher end drugs, even if they were pan sensitive, we did not release the second line reports. Only if the clinician the specific reason, unless then the second line drugs. If the first line, three or more, if 3 different antimicrobial groups are sensitive, then thoughts of, I will give a feedback form, Google form. So in that you can mention, I will add this point. So please give your views, because then back end. So usually these are persuasive strategies. So audit and feedback. This is more data based. So prospective audit and feedback. This is more difficult. Retrospective is obviously easier. Okay, and pathogen directed AMS audit. So this we are doing, not audit wise, but yes, we are I formulated a pathogen directed list of antibiotics that we give specifically to that pathogen. So yes, we can start as an audit also. Prescription audit, we just discussed all these audit forms in previously. And antibiotic timeouts and reviews. And timeout is nothing but you review, this is a prospect, you will stop it after like 48 hours or 72 hours of review and
prescribing day-to-day practice. This is majorly for surgical branches coming here. So why it is very important? First, antimicrobial resistance is a global threat. By end of 2020, based on multi-drug resistant organisms, if patient has acquired infections in the hospital, and patient will be, this is the most leading cause of death. Usually cerebrovascular diseases and cardiovascular diseases and accidents, cancer during perioperative physicians. And principles of antimicrobial prophylaxis, objective is prevent surgical site infections and morbidity and mortality. And to select the ideal agent and use in the appropriate way, and we have to work against pathogens most likely to contaminate site with consideration of their resistant patterns and shortest effective duration and correct administration to ensure optimal concentration during the procedure and minimize the adverse effects. These have minimal adverse effects like usually adverse drug reactions from antibiotics and complications like Clostridium difficile infections. There are certain forms of antibiotic treatment, whether it is prophylactic antibiotic therapy and empirical antibiotic therapy and targeted antibiotic therapy. As a perioperatively, before we will start prophylactic antibiotic therapy, here antimicrobial prophylaxis begins with the idea of no infection exists, but during the operation, there can be a low level of inoculum of bacteria introduced into the body. If an infection is already present, then this form of antibiotic is the empirical treatment are presumed to be present, then antibiotic prophylaxis we can decrease to 6%. For diabetes surgeries like acute cholecystitis with spillage of pus from bladder, another like bowel obstruction with enterotomy and spillage of curtain, their infection rate up to 40%, we can decrease infection prophylaxis by 7%. So based on type of surgery, we have to decide which antibiotic, which class of antibiotic we have to give. For intra-abdominal surgeries, usually we can encounter with granulation. So when should the antimicrobial start? Should anyone answer? Within 1 hour, within 3 hours, within 12 hours? Yeah, 1 hour, please. It is an engaging discussion. So already it is a last extensive session. So 1 hour. So why it is 1 hour? So this is a surviving sepsis recommendation. Whether is shock present, sepsis are present. If shock is present, administer antibiotics immediately, ideally within 1 hour of recognition. Why? They have done the RCTs. If at all every 1 hour of delay of appropriate antibiotics, there is an increase of 10% mortality. It is very, very important. Then in case if patient has not a shock, if a sepsis, then rapid assessment of infectious versus non-infectious causes of this sudden deterioration. If you feel still patient in sepsis, then we have to give antibiotics within 3 hours. So here, whenever these kind of presentation, post what are the possible causes? Usually, any post surgery, whether it is a hemorrhagic shock, or if no DVT prophylaxis, any embolism, or it is a common thing is sepsis. These kind of patient anastomotic leak. So how do you investigate? Good physicians, then our job is enough. So why do I bother myself with these rules? So I can initiate antimicrobials in all patients and be safe? No. So there is an indirect harm to future patients. It will increase the prevalence of multi-drug resistant organisms. By end of 2050, it is the leading cause of death in the overall world. And what is the toxicity to the? So here, these are the most important components. Whenever we are starting antibiotics, we have to know what is the spectrum of this antibiotic and what is whether this antibiotic penetrate the appropriate target tissue or not, and whether we should start only monotherapy and along with combination therapy to cover MRSA coverage and MDR coverage. It is important. Coming to tissue penetration of antibiotics, it depends upon the lipid soluble and water soluble antibiotic. In lipid soluble antibiotics, it has good tissue penetration and high volume of distribution and low blood level, useful in skin and soft tissue infections. And water soluble antibiotics has poor tissue penetration and low volume of distribution and high blood level, useful in bloodstream infections. These lipid soluble antibiotics secreted in bile, good in cholangitis, and these dose modification required in based on liver function. And water soluble antibiotics are secreted in urine, and these are good in urinary tract infections, and they need dose modification based on creatinine clearance. So once this penetration is over, does the antibiotic cover this pathogen is important. Whenever starting antibiotic, we have to know the spectrum of antimicrobial spectrum. Whether this antibiotic cover this spectrum or not, it is very, very important, the thought process. So for that, we have to know what are the classes of antibiotics. Cell wall synthesis inhibitors are beta-lactam group. That day-to-day we will practice. What is the common beta-lactams are? Penicillin, cephalosporins, and carbapenems, and glycopeptides like vancomycin and phosphomycin. Cell membrane disruptors commonly we will use as polymyxins, and protein synthesis inhibitors are aminoglycosides, tetracyclines, macrolides, and linezolid, and folate metabolism inhibitors are trimethoprim and sulfamidoxazole, and DNA synthesis inhibitors are fluoroquinolones. And why this important? Why should we know antibiotic classes? Because whenever giving antibiotics, certain group of class of antibiotics are bacteriostatic and certain are bactericidal. So these bacteriostatic drugs stop the functions of the cells, then the body immunity complete the job. So not preferred in neutropenic patient especially. This linezolid especially we will use very commonly. It is a bacteriostatic drug. So finally, to optimize these antibiotic combinations, this based on bactericidal and static, it is very important. Bacteriostatic drugs stop the functions of the cells, and this might impair the killing effect of bactericidal. So there is an antagonism between the bactericidal and bacteriostatic drugs. So usually we should not use the combine the bacteriostatic and bactericidal drug. So meropenem and linezolid, if you combine, this antagonism will occur. Unless it is very specifically indicated, there is no other bactericidal will not use. So combination of cidal drugs is better. This rationality we have understood before. So to understand their spectrum and certain cell wall synthesis inhibitors are not, these organisms are very important. Whenever prescribing antibiotics, whether we are covering gram-positive cocci or gram-negative bacilli, in gram-negative bacilli, whether we will cover extreme drug resistant and atypicals and anaerobes. These are the only microorganisms we have to cover. For antibiotics cover for community-acquired non-resistant pathogens, especially for atypicals and anaerobes, it will covered by macrolides or doxycycline, and other gram-negative and So till now we are decided in the patient landed up in the sepsis. Then we starting up decided about start the antibiotics in the right time within 1 hour, and still we are deciding the which drug we have to start based on the penetration of antibiotics and the antimicrobial spectrum. Now we have to question whether we should start only monotherapy or multitherapy. Here, whenever deciding empirical antibacterial spectrum, if patient has a risk factors for MDR organisms or MRSA and other high suspicion for pseudomonas and atypical cover, then we have cover with carbapenems, quinolones, and vancomycin. These antibiotics will cover the all spectrum of organisms except extreme drug resistant organisms. These extreme drug resistant organisms will be covered with colistin in case if at all required. So finally, these rules in antibiotic combinations are good combinations will be bactericidal drugs, beta-lactam plus aminoglycosides, or beta-lactam plus beta-lactamase inhibitors. Like commonly, can you tell one example of beta-lactamase and beta-lactamase inhibitors? If anyone? All of exhausted. Yes, excellent. Piperacillin plus tazobactam, cefpoaxome and sulbactam, and ampicillin and sulbactam. These are all beta-lactam and beta-lactamase inhibitor. These antibiotics only day-to-day we will practice. And beta-lactam plus macrolide. And adding clindamycin in necrotizing fasciitis is very, very important. And drug finally, the surviving sepsis recommend for adults with sepsis or septic shock at a high risk of MRSA, they recommended using empirical antimicrobials with MRSA coverage over using antimicrobials without MRSA coverage. If at all low risk for MRSA, they suggest against the use of empirical MRSA coverage. So we have to know what is the risk factors for MRSA. Usually patients with dialysis catheters or long-term antimicrobial therapy or previous MRSA patient colonization. Then for adults with before this algorithm. Again, even surviving sepsis campaign guidelines they recommended, we suggest using shorter over longer duration of antibiotics. I completed some principles of antibiotic regarding the sepsis. Then before also prophylaxis perioperatively. Brief introduction about madam already discussed about antimicrobial stewardship program. Or in case gram negative, we can stop the gram positive coverage immediately. Gram stain is a rapid diagnostic programs and rapid microbiological diagnostics. Like today it is a molecular based diagnostics test and telemedicine driven stewardship. If you have any dilemma in when to stop antibiotics, we can take a consultation from telemedicine from clinical microbiologist, like where
Initial assessment of all the cases they have made certain changes in it, and the initial assessment orders issues were the medical reconciliation forms and the status of allergies and date and time of completion and name and signature were not being properly done. As you all know, this is the initial assessment. This is the newly added column where they have added a chart for this drug reconciliation. If the patient is already on any medication, you should mention what the drugs they're on, route, dose, and frequency, and the last you have to consider it in the progress notes, and you have to add them again over there. And if the patient has any history of allergies, you have to mention, and if doesn't have anything, you have to mention no, but it should be filled. This is regarding the reconciliation form and the allergies. And plan of care, there is a next page after the initial assessment, which is plan of care. Actually, in the plan of care, it is intended that we should write the plan, not the treatment or any medical management as such. And in the last column, there's a signature with a name. There, the primary consultant should countersign the initial assessor sign. And at the date and the time for the cases attending the ER, for the ward cases and the ICU cases, there are different designated times in which the initial assessment has to be done. For example, if the case enters the ER, the initial assessment has to be done within 20 minutes of the entry. And if it's in the wards, it should be done within 1 hour. That is 60 minutes of the admission. And in ICUs, it should be within 20 minutes of admission. If there is any delay, that means the patient clearly indicates that we have not seen the case and the initial assessment has not done properly. And I think this is most mistaken thing. The referral forms, these are the new forms which have been added, missing the order of the entry, and the resident order should be countersigned by the consultant. Required documentation for consent. There are many consent forms like general high risk and transfusion consents. In most of the consent forms, the date and time is being missed, and the patient details. In certain consent forms, the consent will in itself will indicate the procedure like sedation consent or transfusion consent. But if you are doing appendectomy, if the patient has any severe pain abdomen or any fever for more than 3 days, in which conditions the patient has to contact the ER or the consultant, we have to clearly write the orders. Like regarding how if the patient has certain conditions, you have to contact us immediately. We have to clearly mention there, and you have to mandatorily write the contact number, which can be ideally ER number or the ward secretary or the PG's number for any emergency contact. So these columns has to be filled at any cost. Please make sure that these are being done by your PGs, at least for this. Thank you. Yes. They have to. They're not writing the date and time and the place where and in progress record they're not seeing the patient details are filled or not. They're only concentrating on writing the notes. And if this paper is gone somewhere, they don't know whose orders are these. So they are not seeing whether the patient details are written or not. So many lacunae in the top column also, ma'am. Thank you. Mad, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Stunts, sir. No, sir. They have to write, sir.